Good morning. I thank the EACTA committee for the invitation. My name is Maria Benedetto. I work as an aesthetic and ITU consultant in the Cardiothoracic and Vascular Department at Sant'Orsola Malpighi University Hospital in Bologna, Italy. As you all know, we've been fighting in a war scenario for more than 1 month, but we also know this is a pandemic, and sharing world experience, I think, is mandatory. I will talk about the mechanical ventilation strategies and in particular about the feasibility of ECMO for SARS-CoV-19 patients. COVID-19 is a disease caused by a novel SARS-CoV-2 virus which appeared for the first time in December 2019 and is now a worldwide pandemic. Because it's a viral disease, experience is still limited and must be updated frequently as new information becomes available. Our data in Italy so far showed that 50% of COVID-19 patients have moderate symptoms and recover quickly. 25% of patients develop severe respiratory failure requiring ITU. The mortality for patients who require mechanical ventilation is pretty high, from 10 to 30% and up to 50% in some cases. ECMO should be and can be life-saving for severe forms of RDS. As in general for RDS, the mechanical ventilation strategies should be tailored for each individual patient according to its lung mechanical properties, should be titrated to achieve safe lateral pressures below 30-32 centimeters of water and should aim to achieve normal values of pH and acceptable gas exchange. However, we cannot consider COVID-19 associated pneumonia as a classic RDS, especially at the disease onset. Two key concepts we have to consider at the lung disease onset: compliance and hypoxia. Compliance because more than 50% of these patients have normal or nearly normal lung compliance. Hypoxia because the majority of patients is severely hypoxic. The evolution of pneumonia observed so far allowed clinicians to identify two types of COVID-19 associated pneumonia: type A or low inflammatory phenotype and type B or high inflammatory phenotype. Only type B may be classified as a classic form of RDS. Which are the initial signs of respiratory stress in type A pneumonia? Severe hypoxia, not necessarily severe dyspnea. Initial response to hypoxia is increase of tidal volume. Respiratory rate and dyspnea may be late symptoms, especially when lung compliance is over 50 milliliters of centimeters of water. And which are the chest CT scan findings in type A pneumonia? First of all, we have to say that the CT scan is even more sensitive than PCR. It has been shown to have a 55 to 98% sensitivity in detecting COVID-19 at initial presentation. And it always shows areas of consolidation and ground glass opacity, interstitial thickening, and bilateral peripheral parapleural involvement. Now the question is, when crossover from type A to type B takes place? We can answer this question considering that when tidal volume increases, negative pleural pressure increases as well in spontaneously breathing patients. This leads to an increase in pulmonary blood flow, and this can cause pulmonary edema, the initial phase of RDS. And when pulmonary edema overcomes pulmonary gas level, we fulfill the criteria for the definition of severe RDS. And which is the potential evolution, clinical evolution, from type A to type B? Severe dyspnea, severe hypoxia, and chest pain. In those cases, a urgent call for an intensivist is needed. And what will be the CT scan finding at this stage? Well, we will find ground glass opacities in non-dependent lung regions in 86% of cases. Bilateral peripheral involvement in multiple lobes in 82% of cases. Progression to crazy paving patterns and consolidation in 64% of cases, and vascular enlargement in the lesion in 71% of cases. Ground glass opacities indicate partial filling of air spaces in the lungs by exudate or transudate. We can surely say that CT scan plays a big diagnostic role in this kind of pneumonia. Chest CT scan at hospital admission and at least after 1 week should always be performed in order to monitor the clinical evolution. Through the chest CT scan, in fact, we should always monitor the evolution from low inflammatory to high inflammatory phenotype. Now we have a few questions to answer. How to avoid crossover from type A to type B? Well, we should always stop the best choice between non-invasive and invasive mechanical ventilation. In order to do the best choice, we should always ask ourselves if patient is generating excessive pleural negative pressure, and we should know how to measure the pleural pressure swing. The gold standard to measure the pleural negative pressure is the esophageal balloon, which is not always available, especially in a pandemic scenario. When esophageal balloon is unavailable, especially in a pandemic scenario, we should always consider surrogates of excessive negative pleural pressure, clinical sign of severe dyspnea, excessive invasive systemic arterial pressure curve oscillations, and paradoxical movement of respiratory muscles. So if patient presents one or more of the following: severe dyspnea, excessive systemic arterial curve oscillations, paradoxical movement of respiratory muscles, or he is not receiving any benefits from non-invasive ventilation after 24 hours, then let's go for intubation. Because timing is the key factor, and in 48 hours, lung function may dramatically fail. So we should put the lung at rest as soon as possible. Early intubation allows us to stop tirage and to reverse the increase of negative pleural pressure. In 48 hours, patients can develop severe DS and be potentially affected by bacterial superinfection. After having presented the two phenotypes of COVID-19 associated pneumonia, a further step is to describe the ventilation key concept for each phenotype. Ventilation in COVID-19 patients is performed in most cases in volume control modality. So for type A, we will choose in most cases a volume control ventilation with a tidal volume of 6 ml per body weight, per ideal body weight. They generally have high compliance, so not so many lung regions need recruitment. They don't need high PEP, so we always have to set the best PEP at the lowest driving pressure. Prone position may be useful, but not always necessary, so we will choose case by case. And we always have to ensure the lowest possible respiratory rate. And how to treat type B? So volume control ventilation is again chosen in most cases with a tidal volume from 4 to 6 milliliters per ideal body weight. In these cases, there is a severe decrease in lung compliance, so many more lung regions need recruitment. They need higher PEP. We always have to set the best PEP at the lowest driving pressure. We have to ensure the lowest possible respiratory rate based on pH and try 5 to 7 cycles of prone position to recruit non-dependent lung region. We all know the general methods for selecting PEEP during RDS. The first trials on COVID-19 patients showed it is a better choice to use the incremental PEP method to set the best PEP, especially in type B pneumonia. This means an increase of PEEP in 2 centimeters of water steps up to a maximum of 15 centimeters of water. We should always consider alternative ventilation strategies, especially when lung compliance is minor than 40 milliliters over centimeters of water. The first alternative ventilation is the APRV, airway pressure release ventilation, which uses high continuous airway pressure to promote alveolar recruitment and to maintain adequate lung volume and the time cycle release phase to a lower pressure in supplementing spontaneous minute ventilation. A longer end expiratory pause from 0.17 to 0.7 seconds reduces dead space fraction and enhances CO2 washout. Another alternative ventilation strategy is the RV, inverse ratio ventilation, during which the ratio of inspiratory time to expiratory time exceeds 1. It can be achieved using either volume or pressure modes of ventilation. Prolongation of inspiratory time may result